Hello and welcome back to the Yale20. My name is Dennis. I'm here to take you through the cirrhosis management module, which I created with my mentor, Dr. Garcia Sao, one of the preeminent hepatologists and a wonderful educator who attends regularly here on the liver service. So as in all Yale20 modules, we start with a 5-minute bedside assessment. How sick is my patient? What is the overall triage approach? Think about clinical scores that can help that triage approach. Above all, think about pathophysiology that then helps you to make clinical decisions. Next, diagnosis. It's important to think of the etiology, and specifically for cirrhosis, how can you manage or diagnose specific decompensations? Treatment, you're targeting each decompensation. And finally, assessment and plan. How do you write it all up so that you can comprehensively communicate to your colleagues through the electronic medical record, as well as have a presentation that is succinct, contains all the relevant clinical information for cirrhosis. All right, so let's get started. 5-minute bedside assessment. You have to think about cirrhosis not as one population, but as 3 subpopulations within that population. And this will help you with triage. So first is compensated. This is bad. All of these patients have end-stage liver disease, but in this population of patients, they're able to compensate using their physiologic mechanisms so that they don't have the what we call decompensations. The main thing you need to know for this first part is that you use portal hypertension, which is the pressure that is measured when you have such a fibrosed liver, the pressure in the portal vein. So usually this is greater than 12 millimeters of mercury in patients with cirrhosis. We'll go over in the pathophysiology in a little bit, but this usually leads to varices, or basically enlargement of the venous system upstream of the liver. Main thing is, if it doesn't bleed, even if they're varices, they're compensated. Second, we think about decompensated. So this is from bad to worse. These are patients who not only have varices, but they have a variceal hemorrhage. They bleed from the varices. Patients who have ascites, large bellies, because of fluid going into the abdominal cavity where it should not be. Encephalopathy, where they're confused. Spontaneous bacterial peritonitis, which is related to ascites in that the fluid inside the belly becomes infected. Jaundice, which is high levels of bilirubin, reflecting an inability to clear out toxins. Finally, we go to further decompensation, or worst. So this is when not only did you have one bleed, but you have multiple bleeds. Not only do you have ascites, but they're no longer being controlled with medication. You continue to have encephalopathy, continue to have infections in your belly, and one very dreaded complication is hepatorenal syndrome, which we'll also go in more detail later. Let's zoom out and think 5-minute bedside assessment. When I see a patient with end-stage liver disease or cirrhosis, I want to think, are they compensated, decompensated, or further decompensated? So let's go to our traffic light. If we're compensated cirrhosis, where they may have varices, they may not have varices, but no bleeding, these are patients who can be treated as an outpatient. Patients who are compensated cirrhosis but have another medical illness that could tip them over from bad to worse, these are patients who could be admitted to the medicine ward, and you can consider a liver consult. If you have decompensated cirrhosis or further decompensated cirrhosis, these are patients that definitely need to be admitted. At Yale, we have a specified liver service called the Klatskin service, named after Gerald Klatskin, one of the preeminent hepatologists of his time, and definitely liver consult to help you manage these patients. These patients have high mortality rates, and they're very complex. I want to take it back to the patient. This is just a schematic that you can see. These cirrhotics look very different from most of other patients that you might see in the hospital. And you can go through all these different areas to see where the decompensations are. So I want to start from head to toe. First, you want to think about decompensation of encephalopathy. You want to think about variceal bleeding. You want to think about ascites. You want to think about spontaneous bacterial peritonitis. And then finally, you want to think about the kidneys. In all of this, remember that you have the spectrum from compensated to decompensated to further decompensation. A helpful score that you can use is called the Child-Turcot-Pugh classification. So this is a classification that can be used to triage patients quite easily. As you can see, Class B and Class C are red, which means that they're increasing level of severity. And it just correlates with the decompensations that we're going to talk about. So, for example, encephalopathy, if you're pre-comatose or comatose, then you're most likely going to be a Class C patient because these kind of go together. If you have ascites that's mild to moderate or tense, that counts in the schema but this one you always want to think about spontaneous bacterial peritonitis. And jaundice is always a red flag in a patient who has jaundice, and you want to be highly vigilant. Fun fact, Dr. C.G. Child was a surgeon who developed these criteria based on eyeballing patients and assessing if they were fit for transplant surgery. Again, look at the patient, examine the patient. That's of paramount importance. Finally, I just want to mention the MELD score, which is used for liver transplant allocation. So basically, who gets a liver? This is used to rank patients and predict mortality, and the range is from 6 to 40. Now let's go through the decompensations a little more systematically based on the pathophysiology. So, again, cirrhosis is scarred over liver, end-stage liver disease. So this leads to portal hypertension, which gives rise to these decompensations, variceal hemorrhage, ascites or spontaneous bacterial peritonitis, and finally hepatorenal syndrome. Portal hypertension causes increased systemic and splanchnic vasodilatation. This is mediated by multiple small molecules that you don't have to know for this purpose, but just know that because of the pressure that's built up upstream of the liver, you have increased dilatation in the systemic and splanchnic beds. This leads to collaterals forming because of the pressure. You want ways to get rid of the pressure, which leads to varices. Varices can bleed. Another thing that happens with the dilatation is that you have a decreased effective arterial blood volume. So think about it as the heart is downstream of the liver as the portal vein brings blood through the liver and into the heart. If you're not able to bring as much blood, or the heart senses there's not as much blood coming through because the liver is so cirrhotic, the heart will think and the rest of your body will think that you have a decreased effective blood volume in your arterial system. This leads to increased compensatory results. So this is neuroendocrine, the ROS system, renin, angiotensin, aldosterone system, sympathetic nervous system, and of course ADH. This leads to sodium retention and water retention, which is your normal physiologic response, which leads to ascites. Or if you have end-stage physiology, then you can have renal vasoconstriction, where the kidney is just completely trying to hold on to as much as it can. This leads to the dreaded hepatorenal syndrome. Hepatic insufficiency. So this is when the liver itself cannot fulfill its functions. Leads to coagulopathy, either thrombosis or increased clots or increased bleeding, and impaired ammonia metabolism. Hepatic encephalopathy is a mixture of these two, where you have impaired ammonia metabolism with a recirculation of ammonia leading to hepatic encephalopathy right here. Jaundice is because of impaired bilirubin conjugation. Usually see it when bilirubin is greater than 3. And finally, impaired synthetic function, albumin and INR are affected. Moving on from triage to diagnosis. Why is my patient cirrhotic? This is more of a reference slide, so don't get crazy about memorizing all of these things. The main thing is it can be cholestatic or non-cholestatic. Non-cholestatic means that it involves primarily the liver and not the biliary system. And the most common are alcohol cirrhosis, hepatitis C cirrhosis, and metabolic disease. Non-alcoholic steatohepatitis is a rising cause of end-stage liver disease in our population as we get more obese. So ask why. If they have a history of prolonged alcohol use, if they smell of alcohol, probably are coming in because of that. And it's really important to think, if they're jaundiced, are they having alcoholic hepatitis and not a decompensated cirrhosis? Hepatitis C cirrhosis, usually associated with IV drug use. NASH cirrhosis, which is a diagnosis of exclusion. Or autoimmune cirrhosis, which is something that's very rare, but something that you should always think about, especially in a patient without these risk factors. Let's go back to decompensation. What I like to think about is 3 bears. Bad, worst to worst. Just want to make sure bad is they have portal hypertension and maybe a varix, but no bleeding. Worst is when you have bleeding varix, ascites, encephalopathy, spontaneous bacterial peritonitis, or jaundice. And worst is when you have a recurrence of these things plus hepatorenal syndrome. When you think about the tipping points that bring you from compensated to decompensated, you have to do a full history to really understand what's going on in this particular clinical scenario. First, think about structural hepatic injury. Most commonly, alcohol, followed by drugs, ischemia, or very rarely acute viral hepatitis. But you want to also think outside the liver. So bacterial infections are number one thing. Spontaneous bacterial peritonitis can be a precipitant, but it's also decompensation. And urinary tract infections, pneumonia, cellulitis. These bacterial infections can precipitate the other decompensations as well, specifically hepatic encephalopathy, AKI, or acute kidney injury, and worsening ascites. You can look through these on your own. These are the other precipitants that you might think of. All right, so now we're here to treat. So when you see a patient with cirrhosis and you've identified they're decompensated cirrhotic, what do? Address the variceal hemorrhage if they're bleeding, fill the tank, fight the bugs, support the vessels. Encephalopathy, they're very confused or somnolent, find and flush. Spontaneous bacterial peritonitis, appropriate antibiotics ASAP. And acute kidney injury, search and support. Go through each of these in turn. First, variceal hemorrhage. This is very obvious. They're bleeding from either their mouth or their anus. Gastric varices, esophageal varices, or rectal varices. Carefully fill the tank. You want to manage it as you would manage GI bleed with some. First, you want to target hemoglobin of 7 to 8. Overtransfusion does not improve outcomes, as shown by Villanueva et al. In the New England Journal. The goal is a blood pressure of systolic 90 to 100, or heart rate less than 100. And you want to make sure the first steps, get a type-in screen, get large bore peripheral IV access ×2, and use packed red blood cells with IV fluids to help resuscitate the patient. Second, very important, fight the bugs. You want to prevent infection, which is a common complication, and it's been shown that giving antibiotics during a variceal bleed improves mortality outcomes. Ceftriaxone 1 gram a day for 3 to 7 days. Finally, support the vessels. Decrease the portal pressure, use octreotide, and second, you want to get GI on board immediately so that they can get endoscopy within 12 hours to ligate those bleeding varices. Next, hepatic encephalopathy, find and flush. If they're pre-comatose or comatose, remember child class 3, then you need to transfer to the medical ICU to protect their airway. So find, investigate infection, pre-renal azotemia, GI bleed or constipation, stop diuretics, and flush. If they're awake, you want to titrate to 3 to 4 bowel movements a day, lactulose, which is a very effective laxative, or rifaximin. The idea behind this is that encephalopathy is caused by something called ammonia. And ammonia builds up in your system because 1, your liver can't metabolize it, so remember from the hepatic insufficiency, but 2, it keeps on recirculating your blood because of the collaterals. This ammonia then goes to your brain, high levels cross the blood-brain barrier and cause confusion and somnolence. Lactulose and rifaximin act on the interior of the gut to then destroy the bacteria that produce more ammonia so you don't then absorb more, and then you can flush out all the ammonia that's built up inside the lumen of your gut. Rifaximin stays in your gut. It doesn't have as minimal systemic absorption. Somnolence, so they're sleepy and pre-comatose. You want to clear their bowel movements as much as possible with enemas from below because you don't want them to aspirate from above. Either use tap water enemas until clear or lactulose enemas. Acute kidney injury, search and support. The definition of AKI is an increase in creatinine greater than 0.3 from baseline. Stop all medications that can affect their fluid status or circulatory system, so diuretics, vasodilators, beta blockers, any non-steroidals, because those can exacerbate kidney injury. The goal is to first determine a type of AKI. Is it pre-renal, intrarenal, post-renal? And the way you do this is you do a straightforward workup with urine sediments, electrolytes, and albumin, investigate the infection, renal ultrasound, and support the kidney by giving them IV albumin, which is a form of IV fluids. The diagnosis of exclusion would be hepatorenal syndrome, which I'm not going to cover in this talk, but this is something that you want to be on the lookout for. Finally, spontaneous bacterial peritonitis, appropriate antibiotics ASAP. Step 1. If you see someone who comes in with a large belly, maybe some pain, you want to diagnose whether or not they have spontaneous bacterial peritonitis. It's positive if you have greater than 250 polymorphonuclear cells in the acidic fluid. So you need a diagnostic paracentesis on admission and day 2. Fluid studies send for cell count, albumin, total protein, gram stain, and fluid cultures. Get albumin so you can calculate the SAG, or serum to acidic albumin gradient. The SAG usually comes back really fast. Determine whether or not it's a transudative from just portal hypertension or if there's something in the fluid that shouldn't be there. Of course, the diagnosis is 250 polymorphonuclear cells. You adjust for white blood cells. I'm not going to go through that, but you can go and look at that later. Step 2, antibiotic therapy is usually 7 days, and you want to think about whether or not this is a patient who has exposure just to community pathogens or they're coming from a healthcare environment where they have more exposure to resistant organisms. Clinical Pearl, do not do large volume paracentesis, even if they have a huge belly, before getting a tap to make sure that you rule out spontaneous bacterial peritonitis. Again, Variceal hemorrhage, fill the tank, fight the bugs, support the vessels. Encephalopathy, find and flush. AKI, search and support. SBP, appropriate antibiotics ASAP. After you've taken care of this patient in the acute setting, you want to think about maintenance therapy. So first, for varices, we'll go through the pathophysiology. Portal hypertension leads to increased systemic and splanchnic vasodilatation, increased portal blood inflow and increased portal pressure gradient, collaterals, and GE varices. What do we do to keep them from bleeding? Well, we give them non-selective beta blockers, propranolol or nadolol, titrated to the limit heart rate of 55 to 60 to prevent medication-induced complications or adverse drug events. Or you can do variceal ligation. However, if they've already had a bleed, then you're decompensated, remember that. So you have to do both non-selective beta blocker and ligation. Finally, if they're further decompensated, you consider TIPS or shunt surgery, which are basically surgical interventions that permanently decrease the pressure that's in the system. Now we go forward. So remember, increased systemic and splanchnic vasodilatation leading to decreased arterial blood volume with neurohumoral responses, leading to sodium retention, water retention, renal vasoconstriction. So this leads to ascites with the first two, and then hepatorenal syndrome with the third. I'm going to talk about ascites. So with ascites, if you don't have ascites, then you don't have to do anything. But if you're decompensated with ascites, then you have to do a negative sodium balance. Salt restrict them and maximize diuretic therapy. So you use spironolactone or spironolactone and Lasix in a 5:2 ratio. This is not magic, but it's been shown to decrease the amount of complications with diuretic therapy. Watch all the electrolytes, BUN and creatinine, and you want to try to decrease their weight reasonably, but the maximum weight loss of less than a kilogram a day. Finally, refractory ascites. So remember, this is from compensated to further decompensated. That means that diuretic therapy has failed, and you want to do large volume paracenteses, stick a needle and take out the fluid, plus IV albumin, very important, or you can do a TIPS. Finally, impaired ammonia metabolism and the collaterals leading to recirculation with increased ammonia, hepatic encephalopathy. If they're decompensated with hepatic encephalopathy, you want to prevent recurrent encephalopathy. Remember, find and flush. In this case, you want to just flush. So you give them lactulose every day so that they can have 2 to 3 bowel movements every day. They cannot tolerate it at all. Sometimes it causes bloating, abdominal discomfort. Then you can give rifaximin, which is an antibiotic that stays in the lumen of the GI tract and decreases the bacteria that produce ammonia. And if they're further decompensated with persistent hepatic encephalopathy, you want to give both. This is just, again, reference slide. Think about how you can prevent patients from getting from compensated to decompensated for variceal hemorrhage, from decompensated to further decompensation for ascites and hepatic encephalopathy. Prevention is key in these patients. How do we write it all up? So, cirrhosis management. First, you want to write compensated or decompensated. If compensated, remember, do they have varices or do they not have varices but still have portal hypertension? Decompensated, what are the ascites? If decompensated, ascites, variceal hemorrhage, or encephalopathy. Go through the etiology, going through each of the decompensations to see yes, do they have it, or no, do they not have it, and then giving information for each one. So for varices, if you have varices without bleeding, were they on prophylaxis? If on prophylaxis, have they gotten a ligation? Which beta blocker are they on? If they're on beta blocker, what's their heart rate? If they have had bleeding, so this is decompensated already, when was the last ligation? Make sure they're on beta blockers, and what is the heart rate? Ascites, if they're non-refractory, then you can give diuretics, and they should respond to it. Tell them what dose, spironolactone and Lasix, 5:2. If they're refractory, how often do they get large volume paracentesis, and when the last one was? Hepatic encephalopathy, are they episodic, recurrent, or persistent? If they're already decompensated, are they on lactulose? If they're further decompensated, are they on lactulose and rifaximin? TIPS. So this is something that we didn't go into detail, but if they've had a TIPS in the past, what was the indication? Hepatocellular carcinoma, vaccination status, and transplant status are things that you don't have to know about when you're helping the patient through that decompensation, but are very useful because the only cure for cirrhosis is a liver transplant. And these are protective mechanisms that we use to help optimize them for that transplant if they're eligible. More information, so you can go to JAMA, the Rational Clinical Exam, Management Treatment of Patients with Cirrhosis and Portal Hypertension, or the Management of Cirrhosis and Ascites. Thank you so much. I hope this was informative, and we'll see you later.